This is my monograph presentation focusing on pressure ulcers. My name is Catherine Kwame. I'm a lifelong learner and lover of new and strange information, so pressure ulcers and wounds are a very interesting topic for me to learn about. Now, why pressure ulcers? Well, I'm confident that we have all taken care of a patient in the clinical setting who has had a pressure ulcer or at least been at risk for developing a pressure ulcer. These are very preventable, and it's important to prevent them because once you have one, they're very difficult to treat. I also just find them very interesting to see what our bodies can do to us and then how our bodies can heal if we take care of them. The patient I'll be focusing on, we'll call her MJ. She's a 75-year-old female admitted from a rehab facility. Her history is type 2 diabetes, active genital herpes. She had surgery on her knee and was recovering in a rehab center. She became progressively disoriented over the past 2 weeks, stopped eating. Her family was not allowed to visit her. When they finally were able to gain access, they found her restrained in bed and they brought her immediately to the hospital for evaluation. Her chief complaint is acute encephalopathy secondary to infection. Vital signs: temperature 97.4, heart rate 101, blood pressure 95/48, respirations 20, and O2 sat 100%. Every single lab value was abnormal. I can give you a couple examples. Her sodium was 132, BUN was 112, creatinine 9.36, ammonia 11, white blood cell count was 22,000. She had a urine culture done. It was positive for yeast, blood, protein, white blood cells, and bacteria. Her Braden score was 13, which puts her in the high risk category. She had a stage 2 pressure ulcer on her left heel. Her right and left buttocks had stage 3 pressure ulcers. Her perianal area was basically one open wound that was moisture related, and she had a mixed venous arterial ulcer on her right leg that was unstageable. Her doctor was not sure what was going on with her, so wasn't giving her any medication. She was prescribed insulin for diabetes and was on enteral tube feedings. This monograph was on pressure injuries and pressure ulcers. A pressure ulcer, as we know, is a localized injury to the skin and underlying tissues, typically over bony prominences, caused by pressure shearing and friction that decrease blood supply to the area and leads to tissue ischemia. They are staged 1 to 4, and then also have unstageable and suspected. In current practice, prevention is key, which can be done by identifying people who are at risk, performing proper skin care, using pressure reduction devices like waffle mattresses and boots, and providing education to families and patients. Trinity uses the Braden scale, which looks at sensory perception, moisture, activity, mobility, nutrition, friction, and shear. The lower the score, the higher the risk. The problem the monograph noted was that there is no real consensus as to what methods are most effective for prevention. There's scanty evidence that any of the methods used are significantly effective. The first article that I focused on was called Supplementing the Braden Scale for Pressure Ulcer Risk Among Medical Inpatients, the Contribution of Self-Reported Symptoms and Standard Laboratory Tests. This was a level of evidence 6, a single descriptive or qualitative study. The aim of this study was to create a more focused assessment of protocol to identify patients at risk for pressure ulcers. So rather than just using the Braden scale, they wanted to, on all patients, they wanted to be able to narrow in on who is really most at risk so that we can get prevention measures in place more quickly. They had patients fill out a demographic form with their age and gender. They looked at comorbid conditions and what symptoms they were currently having, and then they used the medical charts to get their lab values. The results listed highest risk patients are those who are older age. These patients are more likely to report pain, drowsiness, be incontinent, and have edema of their extremities. They're more likely to be immobile and unable to perform their ADLs, And they'll have low levels of albumin and hemoglobin, as well as high levels of C-reactive protein. This is significant because pressure ulcers develop quickly, and prevention needs to start as soon as possible. Focused assessments could be a part of this. So the main takeaway from this is if you have a patient who comes in who's incontinent and immobile and reporting pain, and then you see their lab results and they have very low levels of albumin, that should immediately trigger your brain to think this patient is at a high risk for a pressure ulcer, and we need to be very careful to make sure that we are doing all we can to prevent that. For MJ, she had all of these symptoms, and so was at a really high risk of developing pressure ulcers, which she did have, as noted, quite a few of them. The second article was Pressure Ulcers in Older Hospitalized Patients and Its Impact on Length of Stay, also a Level 6 article. The aim was to determine what the effect pressure ulcers had on the length of stay in the hospital. They found that pressure ulcers increased the length of stay from 9.9 days to 19 days, which is a pretty significant increase because, as we know, having a longer stay in the hospital increases the risk of functional decline and having hospital-acquired infections as well as costs. The article also found that time in the ICU and mechanical ventilation and infection were more prevalent in keeping people in the hospital, but that pressure ulcers were very contributive to long hospital stays. Now, this is applicable for my patient because her wounds were infected, which was making her decline, and they were also keeping her from getting a lumbar puncture because they were on her back, and so she's going to end up being in the hospital for a considerable time due to her wounds. Assessment, as we know, is key. You'll want to assess risk analysis with the Braden scale, look at laboratory findings, do a full skin assessment, do a wound assessment, both initial and then ongoing, each time you do a dressing change, and to assess for factors that slow wound healing, like low perfusion, poor nutrition, and immobility. For MJ, her wounds were assessed and staged by a wound nurse. She was incontinent and so needed frequent moisture checks and changing of the perianal area. She was on enteral tube feedings to improve her nutrition and was turned every 2 hours for prolonged immobility. And as you remember, her blood pressure was very low, and so she definitely has low perfusion issues that need to be addressed as well. The monograph for data analysis suggests looking at the serum albumin, protein, lymphocyte, and monitoring wound culture results. For MJ, her albumin was 2.3, which as you can see is very low. Her total protein was 5.0, which is also low, and her lymphocyte count was 13%, which is also low. Her wound cultures were pending. The infectious disease physician said that the infections in her wounds were likely contributing to her overall decline and her encephalopathy. For planning and implementation, the interventions that were recommended in the monograph and also utilized with MJ were turning every 2 hours and using the lift sheet and propping on pillows to have her face different directions. They also used a waffle mattress and boots, proper wound care, and she had gauze, Zeroform, and Mepilex, and then she also was on enteral feedings to provide adequate nutrition for healing. Next steps for MJ were to manage her incontinence and do, I think, more frequent checks to make sure that she wasn't wet or dirty, and then also to try and use some skin barriers to protect her area since it was pretty damaged, and then also to manage her pain. She was not on any pain medications during any of this, and I feel like that is a poor management of her because I do believe that with all these wounds and everything going on that she must have been in pain. Discharge planning. The monograph lists education on prevention and follow-up, having home health nurses come to do a home risk assessment, and then using an interdisciplinary team. This is complicated for MJ. There were obviously some shady practices going on at the rehab facility where she was located. She was transferred from Rock Island to the University of Iowa Hospital just due to the complex nature of her care. And she did have a lot of doctors and other medical professionals on her team. She had the hospitalist, a nephrologist, a infectious disease physician, wound care nurses. If she makes it through everything, she'll definitely need some PT, OT, and some speech and language pathology assistance. Evaluation, the goals that were listed in the monograph: that pressure ulcers heal and no new ones develop, that adequate nutrition to promote wound healing, that there are no complications secondary to the wound, such as sepsis or a loss of a limb, and the patient and family understand how to prevent pressure ulcers. For MJ, the nurses were working steadily and the PCTs to help heal her current ulcers and to prevent new ones by all the methods we talked about. Her enteral feedings were helping her with her nutrition. Treat new infections as ordered. Right now, she was on no antibiotics for her infections as they were waiting for the wound cultures and weren't able to do a lumbar puncture. And then, as always, provide education. For this patient, it's important to focus on prevention. We don't want the pressure ulcers to get worse, and we don't want to get more. So we continued to do skin assessments and wound assessments with each dressing change, and then turning, incontinence management, waffle mattress and boots, and then wound care. Also, we monitored labs. Are we trending in the right direction? So daily lab draws to make sure things are getting better and not worse. Nutrition, as we've talked about, is essential for healing, so continuing to do the enteral feedings to get nutrition into the optimum range. And then ethically, I wonder if doing something is better than doing nothing, even if it might not be the right something. So what I mean by this is, for infection control, perhaps starting her on a broad spectrum antibiotic could be more beneficial than sitting back and waiting. And I'm not a physician, this is not my call, but it's just something I think about. Same with pain management. Maybe we start her on a pain medication to try and manage her pain now instead of waiting to see what happens later. In conclusion, these are the big takeaways. Prevention is key. Wounds are difficult to treat once you have them. They can lead to pretty serious complications, so it's better if a patient just doesn't get them in the first place. It's important to work as a team. Use the wound ostomy nurses. PCTs are absolutely vital for this. They're the ones mostly doing the turning, cleaning up with incontinence, and just keeping you informed if they see anything change as they're in and out of the room. Working with a dietitian, and then specialty physicians. She was having some kidney problems, she had infectious disease, and so just all communicating so everyone's on the same page. And then also to remember that labs are more than just numbers. To look at the values and really think about what the consequence might be for your patient. So for MJ, her albumin was very low. So if we can raise that up, perhaps it will help her to not get more pressure ulcers, and it will help her healing. And then don't forget your small stuff. Remember your nursing process. Remember to document. All of that is always very important. Even if it seems like it's not the most exciting thing to do, it is essential for excellent patient care. Thank you so much.